Is that me, David?
That's you, David.
Yeah. So this is an interesting point. So we were just talking in the room, and I've asked the people in the room to form their own opinion as they're watching this of what they think's going on, because we all know that this is an exceptionally difficult case, right? The reason that's referred here is because the person who did it, a very experienced gastroenterologist, did not know really what was going on. So that's why it's been referred here. He's biopsied a couple of times something that's shown low-grade dysplasia and has found nothing endoscopically. So that's the reason the patient is here. So of course, it's not an easy case. Try to avoid traumatizing the mucosa, Michele, if you can. So the question is how we deal with this complexity, because it is a lot. And how we have a structured, more deconstructed, structured approach to this problem, because it is not unsolvable, but it is definitely difficult. So, I mean, David, I've seen you coaching Michele very nicely to slow down. I mean, Michele, we have to say Michele is very much at the start of his endoscopic career. So that's the first thing is, for example, Michele, you have a cap on. Do you want a cap on right now? Is it helping you, or is it actually making it more difficult?
I think that now that I want an overview, maybe is not helping me, but
okay. So take it out and then take it off, and let's do our overview assessment first.
Yeah, we'll go back to white light.
So I think what we have to do in any sort of extreme complexity is apply a structure to the problem, right, Tomas? You're a man who likes to apply a structure to a problem, right?
I hope so.
Yeah. So the structure I would apply is meticulous examination per segment and discussion per segment of what we find. And if we find anything that is either a bystander finding, because I think I've seen a bystander finding, or that is irregular in its structure. These are the two things that I will be trying to ascertain per segment of the stomach. And I think it is excellent. I think it does draw lesions out. So maybe we can use this mode to examine the proximal stomach. So you have to do what we did yesterday. You really have to expand the proximal stomach, and that means sitting on the CO2 button. And while you're doing that, you can make an assessment of the sphincter competency there.
We have to look at the palisade vessels also for every case.
Remember the palisade vessels when we have the cap on later?
Yeah.
So it's quite a competent lower esophageal sphincter.
Yeah.
You agree, David? It's quite competent, that?
Yeah. Yeah, it looks pretty normal.
Okay. Well, you've got a nice view now, haven't you, of the fundus? So why don't we have a look in there?
Sorry, can you repeat?
You've got a nice view of the fundus, yeah.
Okay.
Yeah.
So in contrast to multiple previous examinations, we can really see the fundus here. And I think, David, do you agree that that's because of the competency of the lower esophageal sphincter, probably?
That's helped, but it is showing us that this whole stomach is abnormal. It's really not. Maybe the antrum and incisure a bit more, but everything is a bit abnormal. So it's really going to be one that needs very close surveillance.
Okay. So I think we've done a good overview.
I think that it's very important in this kind of cases to be systematic. And at the beginning, I was not having this approach, maybe because I'm waiting for your request. But I think that is very important, because when you enter in a stomach that is that this level of disease, if you are not systematic, you will definitely miss something.
I can just give a summary of a brief discussion we've been having about the maths about it all, and I don't want to undermine the published data, but you'd expect more cases of gastric cancer based on the data for intestinal metaplasia, and I would also suggest that is probably made even more stark by the fact that we underdiagnose intestinal metaplasia. So I'm not sure that the risk is as great as we think. I'm not diminishing the fact that we need to do this thing properly, but it's an interesting theoretical exercise.
Yeah, I think that's probably fair. I think the studies are probably biased in that regard, aren't they? All being from centres where these things are commonplace and sent up, etc., etc. But nevertheless, that doesn't take away from any of this, because good practice is good practice.
Comes back negative. I don't know.
This is very common finding in this. Particularly, I think that all of the biopsies that we would have taken today would have come back as atrophic gastritis, potentially some of them with intestinal metaplasia.